Thanks for joining us today on a really great talk. Just a few housekeeping things first. Just instructions. I'm sure you guys have been through it before. Make sure you're on mute unless you're the speaker. And then, feel free to share your video. I think the more people that do, the more lively the discussion is. And I think, it's just fun to see everyone's faces, especially in this COVID era. If you want to ask a question, feel free to write it in the chat, either privately or, to the whole group. And then towards the end of the lecture, we can go ahead and note all your questions and then hopefully get them answered. And make sure that you have just so we know who's attending, for full name, first and last name. And if you need instructions to do so, you can see those right here. Lastly, CME accreditation. To claim CME, you have to complete the following after each webinar, which is an evaluation form and a post-test form. At the end of the talk, you'll get a link in your email, so just use that. But if you don't know, or if you didn't receive an email, make sure to write this email down, and you can always email them and then ask. Your program evaluation form and request for your CME certificate will be processed by our CME provider, and you'll receive your certificate via email in 4 to 6 weeks after completing the series. Online evaluation form. To claim the credits, you can complete the online form using this link. And if you're not sure, again, use that email below and just write an email down, and or write us an email, and then we'll figure it out from there. And for the fellows that are on today, kind of like similar to last time, to replicate a meal, we will offer, or NCSCG will offer a meal for $30 credit to eat at the time of the webinar. It's great if you guys can show your videos and eat. Feel free to eat. There's, it's no formality. To do that, you just have to make sure that you email Danny at this email, dsmith, your receipt, and then you'll get the value check at the end. Grant support are gratefully acknowledged following further educational grants in support of the educational activity: Ferring Pharmaceuticals, Mallinckrodt Pharmaceuticals, and Takeda Pharmaceuticals. All right, so tonight we are here to discuss updates and approach to diagnosis and management of pancreatic lesions by Dr. Walter Park. And the next one we have is just next month, so just keep a note of that, June 22nd, same time. And that would be by Dr. Chandra Ho. These are just the members of the education committee. So thank you all the trainees and everyone for your hard work in putting together this entire series. And most excitingly, the 2021 NCSCG 18th Annual GI Symposium has finally opened up abstract submission. So don't forget to register. It's a hybrid this year, so it'll be in person as well as on Zoom. It's on June 26th through 27th. So registration is open, and abstract submissions are also now open. So feel free to go ahead and submit. And with that, follow NCSCG1 on Twitter, subscribe to YouTube, or follow them on Facebook to get more information. Okay, so with that, I do want to welcome Dr. Walter Park. Thank you for joining us. Dr. Park is an associate professor of medicine at Stanford University and a medical director of the Benign Pancreas Program at Stanford Healthcare. He completed his medical education at Johns Hopkins University School of Medicine and his internal medicine and GI training at Stanford. Currently, his research focuses on translational biomarker discovery for chronic pancreatitis and pancreatic cancer through development of biorepositories with clinical databases. He's currently a principal investigator within an NIDDK and NCI consortium for the study of chronic pancreatitis, diabetes, and pancreas cancer. He is also a principal investigator for the NCI Pancreatic Cancer Detection Consortium and a PI for NIDDK type 1 diabetes and acute pancreatitis consortium. So with that, I'd like to welcome you. Thank you for joining us, and you can share your screen now.
Thank you, Farah, and thank you for having me. It's a real privilege and pleasure. and it's great that you guys are doing this. I'm a big advocate for trainee entities and groups to get together, not just for the education, but hopefully more importantly for just the networking and socialization. So given the time of day, and this is the end of the day for all of you, technically this is a lecture, but I'm going to try to hopefully make it conversational. By all means, feel free to interact and ask any questions. I know there is a chat function. Virtual makes it a little bit more challenging, but I'm fine if you guys, if you have a question, just unmute yourself and just ask. That's okay. So I'm going to talk about, I guess this topic is fairly large, at least from my opinion of being a pancreatic specialist. So I'm going to try to race through what I think are the relevant points about pancreatic lesions. So the way I thought about this was to break it down by solid lesions and then cystic lesions. We'll talk a little bit about solid lesions first. So this is kind of your differential of such, but you know, the primary solid lesion of concern that we all are aware of, that we all fear and talk mostly about, and the most common is adenocarcinomas. And I think the key take-home points is when you think about solid lesions in the pancreas, your first thought is adenocarcinoma, followed by neuroendocrine tumors. But listed below is really a table of a rich variety of histological variants of different types of rare tumor types that you can see that are both primary pancreatic based as well as non-pancreatic based, including pancreatic metastases, commonly kidney and lung, lymphoma, GISTs, and paragangliomas. These are not going to be as common to the more benign variants such as intrapancreatic splenules or inflammatory tumors, pseudotumors from chronic pancreatitis. And so I'm going to focus mostly on the adenocarcinomas and the neuroendocrines, but you know, I think one of the key take-homes is recognizing that there is a rich collection of different types of tumors, and most of you are training in academic tertiary centers. So I hope that along the course of your 3 years as fellows, you'll have an opportunity to see some of these more rare but unique lesions. I'll just start off as most clinical presentations with a case of a 64-year-old who came to our attention for abdominal pain after eating pizza. And he was diagnosed with bread and butter acute pancreatitis, but he didn't have gallstones. There was a biliary stricture, so a stent was placed, and he was referred later on for evaluation. And here's the CPR view of a pancreas and coronal section, and you can see kind of here. I don't know if you can see my arrow, but there's also a stricture right there, but there's no clear mass there. And then, but by endoscopic ultrasound, there is a 3 mass. Unfortunately, proves to be pancreas. Now, what do you really need to know about pancreas cancer? Well, it affects about 54 to 55,000 Americans per year, and it is a cancer that seems to be on the rise. But it's not common enough that we offer screening like we do for colon cancer screening. We estimate the lifetime risk of pancreas cancer to be about 1.5% or 1 in 69. And that statistically is not really high enough to warrant population-based screening. And as I just alluded to, for unclear, we've made successes with colon cancer screening and lung cancer with smoking, anti-smoking campaigns and screening high-risk individuals who smoke. And we're starting to bend the curve on those types of tumors. But if you notice here, pancreas and liver seem to be on an upward trend, and pancreas is on its current trajectory slated to be the second leading cause of cancer death. And that's garnered a lot of interest nationally and internationally. It's raised the eyebrows of the NIH, and they've allocated a lot more funding in pancreas cancer research. Most of us are aware that pancreas cancer is associated with a poor morbidity and mortality, and that's primarily thought due to the late stage of onset of presentation. The vast majority of these patients present with locally advanced or metastatic disease. And the point of this slide is just to show you that if you do detect it earlier in the local resectable stage, the median overall survival, there is a clear difference. And if you look at the 5-year overall survival, you're upwards of 20 to 25%. And I think that's even improving further compared to 0%. Now, granted, that's not great, but the point is that there is a differential difference, that there is a clinically significant difference in diagnosing it earlier. And this on top of the rising prevalence and some other factors that have become more increasingly appreciated about pancreas cancer has also raised a lot of interest in whether we can develop an early detection strategy. And so the U.S. Preventative Services Task Force, as you know, re-reviewed the literature and confirmed the fact that, if you're an asymptomatic average risk adult without any high risk factors, there's really no evidence for screening. And again, that's really a mathematical problem based on the prevalence. The prevalence is not high enough that even if you had a super sensitive and specific test, you still would have a lot of false positives. Now, I think the more important point of this slide is not the top bar, but the bottom bar, is that they start talking and acknowledging that there are high-risk syndromes, including genetic syndromes, a history of familial pancreatic cancer, that does potentially suggest that these are higher risk populations that potentially warrant further screening and surveillance. And there's been a lot of interest in trying to identify who these high-risk individuals are. Both nationally and internationally, and there's been several different consortiums that have been put together to kind of standardize the approach of who high-risk individuals are. And the most current iteration published in Gut in 2020, identifies specific mutations like Putz-Jaeger's, CDK and TA germline mutations, BRCA1, BRCA2, which are quite common mutations, in part because we're screening and testing for them for every patient who has breast cancer. And so we're finding these, and if they have, in addition to being a BRCA1 or BRCA2 mutation carrier, one affected first-degree relative, they do fall into this acceptable risk of acceptable high-risk group, worthy of considering pancreas cancer screening. In terms of what age do we initiate, well, it's similar to what we've kind of done before. We start typically at the age of 50. When you look at, with the exception of Putz-Jaeger's, we generally start at the age of 50 or 10 years younger than the affected first-degree relative. We can start early with Putz-Jaeger's at 40, and with some of other mutations with younger onset, you may start earlier. So, this is about pancreas lesions. So beyond adenocarcinoma, the things that how do adenocarcinomas look on cross-sectional imaging? Well, they tend to be hypovascular. We tend to think of them as lesions that are often mostly stroma and fibrotic lesions with islands of tumor, and they tend to have minimal vascularization in contrast to other types of tumors. They tend to be ill-defined, and when in the head, they often will cause pancreatic or bile duct dilation. Other types of mimics, neuroendocrine tumors, tend to be hypervascular lesions, and I'll talk a little bit more about that in some forthcoming slides, but they can mimic or look like adenocarcinomas. Pancreatic metastatic lesions are also generally hypervascular lesions, particularly the kidney metastatic lesions. And one of the tips to remember is that these are neuroendocrine and pancreatic metastatic lesions, like kidney lesions, tend to be hypervascular in the arterial phase. So if you aren't doing the appropriate arterial phase on a CT image, you actually may miss the lesion. So one of the things just to keep in mind when thinking about hypervascular lesions, I digress because I was talking about adenocarcinoma mimics, but couldn't help since I was thinking about those lesions. Lymphoma, groove pancreatitis, where you essentially, due to swelling and fibrosis, there is essentially a pseudomass that's formed at the second portion of the duodenum. Autoimmune pancreatitis is a phenomenon of late that's increasingly recognized that can present as a focal hypodense mass, as well as inflammatory pseudotumors from chronic pancreatitis. These are just some examples of, this is a couple examples of metastatic lung cancer. Here you can see it on the left in the arrow, you see it affecting the head of the pancreas. It's hypodense, hypovascular, so it can very much look like a adenocarcinoma of a pancreas primary. Here's another example of a tumor in the neck of the pancreas, much smaller, but you can see essentially in the body and the tail an atrophic pancreas. You don't necessarily duct dilation in this particular case, but that also is a telltale sign. This is an example of an inflammatory pseudotumor in a patient who had a prior history of pancreatitis, and this is essentially kind of borderline groove pancreatitis versus inflammatory pseudotumor because they groove because, again, it's in the second portion of the duodenum at the C curve, but you have this clearly demarcated hypoattenuating lesion in the head of the pancreas. Thought to be adenocarcinoma, proved to be just an inflammatory mass of fibrosis. This is another example where you actually have a tumor in the head of the pancreas, but here you have upstream duct dilation that essentially causes duct dilation from the neck all the way to the tail of the pancreas. And it almost looks like a main duct ipmn, where you have a dilation of the main duct. But in this case, it's really just compression and obstruction from an inflammatory focal mass from chronic pancreatitis. As I was saying, neuroendocrine tumors traditionally are hypervascular masses. They tend to be more well circumscribed. Other potential mimics of neuroendocrine tumors besides pancreatic metastases, kidney tumors, are accessory spleens. Oftentimes you'll see them in the tail of the pancreas, a very well-defined brown lesion described as a mass in the tail of the pancreas, which proves to be really just a splenule. Gysts, which often can typically originate from the intestinal tract, may also often grow on the serosal side and may push into the pancreas. So it looks like it's originating from the pancreas, but in truth, it's perhaps coming from the intestinal tract in the duodenum or the stomach. I've had a couple cases in my career of peripancreatic paragangliomas. They tend to be hypervascular. We thought they were neuroendocrine tumors, but then when we did the fine needle biopsy, it turns out to be a paragangliomas. And then some of the more rare types like astrocytic cell carcinomas or solid serous adenomas are less common, but these are some of the things to consider. And in children of pancreatoblastoma. So these are just some pictures of neuroendocrine tumors. Here, this one on the left is a solid hypervascular lesion, approximately about 2 centimeters, with some upstream pancreatic atrophy. It's avidly enhancing. On the other hand, you have a cystic variant of pancreatic neuroendocrine tumors, where here, essentially in the middle, you see a cystic lesion, and then around it, that's hypervascular. That's the actual solid portion of the neuroendocrine tumor. These are thought to be a little less, thought to be more indolent than the solid variants and less common. This is just an endoscopic ultrasound view of a very small 5 millimeter neuroendocrine tumor. I will say that I think in the last 5 years, just as we've seen a lot more pancreatic cysts that we attribute to a detection bias due to increased use of MRIs and CT scans, particularly when MRIs and CT scans are their resolution are constantly improving. So we're seeing smaller and smaller cysts. I think we're starting to see a lot more incidental neuroendocrine tumors, in part because of the imaging resolution. I think we're also doing, in my practice, and doing endoscopic ultrasound, particularly for the high-risk individuals, we're finding 5 to 10 millimeter neuroendocrine tumors, often well-differentiated grade 1, that were not clearly seen by CT or MRI, that we're seeing more of. And so in a way, these are probably more common than we probably thought, and we're just starting to see them better. This is a peripancreatic gist. Here you can appreciate the hypervascular nature and you can see here it's thought to be a part of the uncinate of the pancreas, but in fact it's actually originating from the T2. The D2 or the second portion of the duodenum, where it's pushing into the pancreatic head. This is a case of a peripancreatic paraganglioma, which is essentially nerve sheath tumors. These can be solid and enhancing. They often have a fat plane between the pancreas and the mass. In this case, could not be distinguished. We think of serocystic adenomas or serocystic neoplasms mostly as cystic variants, but sometimes they actually are more solid than cystic, and this is an example of a solid serous neoplasm. These are solid enhancing without typical cystic features, and histologically they're indistinguishable from the serocystic neoplasm or the serocystic adenomas. So, the workhorses for how we image and characterize and how we talk about these are based on CTs, MRIs, not commonly PET studies, but sometimes incidentally so. Endoscopic ultrasound increasingly used, less so with ERCPs. CA19-9 is a non-imaging based marker, but we don't use it for screening, but we will use it when you already have a diagnostic suspicion for an adenocarcinoma. The beauty of CT scans now is that they're the workhorse. They're quick. They provide high resolution 3D reconstruction, and they really help identify the relationship of a tumor to major blood vessels. This is a nice coronal view of a pancreatic head mass causing duct dilation with subsequent atrophy of the pancreatic body and tail. Right here is a common bile duct that's also obstructed from that tumor. MRIs are increasingly appreciated for their use of for their lack of radiation. They provide nice characterization of the pancreaticobiliary system, and with the T1 imaging, they provide some nice imaging of tumor as well as staging. T1 mapping can also provide and characterize and quantify the level of fibrosis that might exist in a pancreatic lesion, so determining chronic pancreatitis versus a tumor. And I think with the rise and increasing recognition of the power of artificial intelligence, CTs and MRI libraries are being constructed to potentially be able to leverage some of these quantitative techniques to help increase the power and the diagnostic potential of CTs and MRIs. PETs are not commonly used, but they have some diagnostic value. They leverage the fact of differential glucose consumption, and there can be increased activity in the primary pancreatic tumor, and metastases oftentimes done for staging, particularly when a chest, abdomen, pelvis is non-diagnostic or unclear. Endoscopic ultrasound, at least is most commonly used for further characterization as well as tissue sampling. That is not otherwise done. This is just a cartoon of a cyst, but just reminding you that it is the workhorse. I will say that what's happened in the last 5 years has really been an advancement of needle technology that's really moved beyond whether we're getting enough tissue to make a diagnosis. That's a given now, given the core biopsy needles that we have access to. But in parallel to that, we've also moved to higher demands where more tissue is sought, primarily for molecular profiling. So these core biopsy needles couldn't have come at a better time because they allow us to provide not only a tissue diagnosis, but enough tissue to grow organoids, as well as do kind of actionable mutation panels that allow the oncologists a better idea to provide the goal of reaching precision medicine and tailoring chemotherapies to specific mutations. The other thing about endoscopic ultrasound compared to CT scans is that it's considered to be more sensitive, particularly for smaller lesions. And so that's, in that sense, in a patient population where you have a higher suspicion for high risk, having a propensity for high risk lesions, that's perhaps one of the values, and that's why endoscopic ultrasound is one of the alternatives or options for high risk individual pancreatic cancer screening. I think we all know that CA19-9, it's interesting about CA19-9. I mean, the basic point is that it's a good test, but it's not sensitive or specific enough that we don't recommend it for screening. And that there are many other non-primary pancreatic causes that can give rise to CA19-9. In my clinic, this is a common referral. Mildly elevated CA19-9, what do you do? Probably shouldn't have tested to begin with. But having said that, I will tell you that a lot of the research pipeline, the tests, the research biomarkers that are being tested that are on the horizon that I'm excited about, that I think we'll start to see being used for screening. One of the research guidelines states that when evaluating a novel biomarker, one should not compare it to just placebo, it actually should be compared to CA19-9. So we're a little bit hypocritical. On one hand, we don't think it's good enough to be used in clinical practice as a screening tool, but we want to see how it performs against CA19-9 because it is actually quite good. And when you look at a lot of the novel biomarkers that are coming out, while there is some value, it's often incremental on top of CA19-9. So I predict that some of the future tests that we'll see for our early diagnosis of pancreas cancer are going to be some combination of perhaps methylated DNA or DNA mutations or some type of immune cytokine profile in addition to CA19-9. It's kind of like Cologuard, where you have the DNA mutation, but it's often the hemocult that often gives a lot of the value. So I'm going to switch gears and talk about cystic lesions, having completed kind of a brief summary of solid lesions. The three main actors, just like solid lesions, there's a rich variety of histological cyst types, to 20 to 30 that you might see in a pathology textbook. But on a clinical basis, the three most common that we probably see are ipmns, cystic neoplasms, and serocystic neoplasms, also called serocystic adenomas. It's interesting because I think if I were giving this talk, 2 decades ago, I would have said the most common cyst is probably the pseudocyst, but probably not the case, again, due to the detection bias in our use of CTs and MRIs. And these are quite common, up to 2 to 3% in the general population over the age of 40. And you can see here in this bar graph to the bottom right that as you age by a decade, the prevalence goes up by 2%. So by the 8th decade of life, the prevalence is somewhere between 10 and 15%, which is quite high. And so these cysts are quite common, and it's a consequence of aging, which really is consistent with our thinking about cancer biology, that in a way, age is the biggest risk factor for most cancers. This is just a graphic of a serocystic neoplasm. These are benign cysts with rare to no malignant potential. In the top left corner is a endoscopic ultrasound view characterized by microcystic lesions, often called honeycombing. In the bottom right here is the CT scan with a central stellate scar, and here's the gross pathological correlation after an operation. And under the microscope, you'll see these kind of glycogen-rich cuboidal cells that are pathognomonic. And I will say that, again, with the EUS core biopsy needles now, I think we're much more capable of getting a tissue diagnosis, preventing unnecessary surgery in patients who end up going Whipple's or distal pancreatectomies for lack of certainty of the nature of their lesion, particularly when it seems to be growing. Cystic neoplasms are characteristically defined by by their location and the demographic. Typically, middle-aged women, typically the distal pancreas and the body or the tail, and they tend to be very simple appearing cysts, unilocular, sometimes 1 or 2 septae at most, with a fairly well-defined capsule. And histologically, they tend to show a rich ovarian stroma, which is kind of the histological key to making the diagnosis. And ipmns perhaps are the most common pre-malignant pancreatic cysts, which come in 2 varieties: the side branch ipmns, which are the incidental cysts that we often see, and then the main ducts, which are less common, but tend to be associated with a higher risk of pancreas cancer at the time of diagnosis, upwards to 40% in many surgical series. And these are the ones that we're following. These are the ones that we're trying to figure out who we can really ignore and who we really need to think about carefully for surgery, or who require closer active surveillance. The clinical relevance, again, is that about 15% of the precursor lesions to adenocarcinoma are these ipmns, or the cystic neoplasms. That's the real clinical relevance to it. And as most of you know, there have been several guidelines, and this actually doesn't capture all of them. There's the European guidelines, the American Society of Gastroenterology have their own guidelines. There's no dearth of guidelines on this in the last decade or so, which, paradoxically, ironically, have rather than create more standardization, has probably created a little bit more variation and controversy. But I think on a research end, it's given a lot of stimulus to supporting more research studies. For example, the AGA guidelines in 2015 basically made a very bold statement saying that we probably could stop following cysts after 5 years if they were less than a centimeter and they showed no signs of growth. And I think strictly from a population health perspective, that probably makes a lot of sense because the amount of resources for doing MRIs to follow these patients for the squeeze of maybe finding one or two cancers might not be worth it. I think it just depends on whether you're the unfortunate one or two. And when you're the physician, whose ethical responsibility is to balance, what you need to do from a population health perspective versus what you try to do to be the best advocate for your patients. It's a little hard to say you really want to stop, knowing that you're really sitting on a essentially the equivalent of a colon polyp. And granted, it's indolent, but if it's in an otherwise healthy young person who might live another 20 or 30 years, not quite clear that's the best course of action for that person. But nevertheless, as an example, that controversial statement spurred and created funding for a multi-center trial where patients are being randomized to stopping versus being followed. And that's being run out of one of the cancer ACOG clinical trial oncology trial groups out of Fox Chase, and they're in the active period of recruitment. My own bias is the international consensus criteria, and this is just a description of kind of how we approach pancreatic cysts. And basically, the general trend has been that we are doing more and more surveillance and less operations, and that we're identifying the key factors that really predict high risk cancer, such as the presence of obstructive jaundice, the main pancreatic duct being greater than 10 millimeters at the time of presentation, or an enhancing solid component within the cyst. These tend to be associated with a higher risk of high-grade dysplasia or pancreas cancer, and should these be present, those would be sole indications to proceed right to surgery in an otherwise surgically fit person. Short of that, then you look for what we call worrisome features, which are cysts greater than 3 centimeters, perhaps a thickened or enhanced cyst wall, a mildly prominent or dilated main duct, maybe a non-enhancing mural nodule if there's abrupt change in the pancreatic duct or with distal atrophy. These are the worrisome findings by which you may justify and think about doing an endoscopic ultrasound for further evaluation with possible FNA of the cyst fluid or of a mural nodule. Otherwise, these guidelines recommend surveillance primarily by a very rudimentary size-based criteria, which works, but if you think about it, it's a little bit rudimentary. It doesn't quite capture the what's probably happening at a cellular level, and I think we can perhaps do better, which is part what stimulates my interest in cyst fluid research. And why the cyst fluid? Well, I mean, ideally we would want it from the blood, but what's nice about the cyst fluid is that it's a relatively protected matrix of fluid with a high concentration of secreted proteins, DNA, RNA, metabolites, hypothetically, which should make and facilitate a better chance of finding a biomarker for high-grade dysplasia. And it's relatively accessible given the ease by which we do endoscopic ultrasound. There's always a question of whether there's a risk of seeding or what are the adverse events, and the data seems to suggest that this is quite safe, that FNA adverse events from EUS is about 1 to 2%. There's no increased frequency of peritoneal seeding seen on a variety of different data studies. One of the large case here is of 243 patients, and as well as a population-based SEER data that really didn't show any detriment. In fact, if anything, an overall improved survival. And I think the increasing role for neoadjuvant therapy in pancreas cancer also makes this less of a concern, because you need to get tissue to start chemotherapy before you consider surgery anyways. When we think about cyst biomarkers, we think about a stepwise approach or a hierarchy of what we want the biomarker to do, right? At a minimum, we want it to diagnose and tell us whether we're dealing with a premalignant cyst. I think we have biomarkers that already do that, but how do we go beyond that? Well, we want to be able to actually tell us what is the cyst type we're actually following. And then even beyond that, what is the evidence of high-grade dysplasia in that cyst? Because that's really the holy grail. Those are the patients we really want to identify and take to surgery, because those are the ones you're going to put off for cure. And perhaps even higher than that is be able to predict malignant transformation risk. And that's where you really need kind of a prospective series of patients where you're collecting the cyst fluid today and serially collecting them over time, and then finding out which patients unfortunately develop cancer, and then that cyst fluid that you collected 1, 2, 5, or 10 years prior to the onset of cancer now becomes your holy grail precious fluid that you'd want to study to see how well a biomarker could predict the possibility of that cancer happening. So we use cytology, CEA, and DNA analysis. Cytology has actually come a long way. We typically think about its sensitivity and specificity as pretty poor, sensitivity 50% and a specificity of 90%, primarily because, frankly, when you aspirate cyst fluid, you just don't have a lot of shed cells for the cytologist to look at. Now, having said that, I think what the cytologists have done over time is they've gotten a little more clever, and they realized that you weren't, if they set the bar to look for actual cells and a certain number of them, they were setting themselves up for basically not being very helpful. But if they changed their criteria and they looked for a certain high-grade atypia among the cells they could see, with that new classification system, they found an improved sensitivity and specificity. And this started out at MGH, and as I've noticed, is slowly making its way in the lexicon of many of the cytopathologists. Although some of the earlier papers were published back in 2010, 2013, I'm now starting to see that in a couple of years ago in my own cytologist using kind of this language. So you can see kind of evidence of dissemination of some of this classification scheme that might make cytology better. CEA is perhaps the most widely studied biomarker in the cyst fluid, and the bottom line is it's okay, it's decent for diagnosing pre-malignant cysts, including ipmns and MCNs, has a diagnostic accuracy of 80%. But the problem is that it not being high enough, it really doesn't change what you end up doing regarding surveillance. So there's been a lot of need to improve upon that. I'm not going to delve into a lot of the research. I'm going to try to keep this mostly clinical. I would say that what has come a long way is molecular analysis, and I think now this is prime time. This is something that we are doing on a regular basis, primarily through an extensive number of studies demonstrating that the presence of a KRAS and a GNAS mutation is basically diagnostic of ipmns. KRAS is basically diagnostic of a precancerous lesion. VHL mutations can be seen, but are not always seen in serocystic adenomas, and CTNNB1 lesions can be seen in the solid pseudopapillary neoplasms. And so when you use this type of system, looking at KRAS and GNAS, you're getting sensitivity and specificities in the 90s to in the high 90%, and compared to the CEAs of 50 to 80%. So this has really affected my clinical practice. Admittedly, I do check CEAs now and then, but molecular analysis using DNA profiling. Because in addition to helping us identify the cyst type or confirming whether we're following an IPMN, there are certain mutations that allow us to identify adenocarcinoma or a high-grade dysplastic cyst, particularly the P53, PIK3CA, and the P10 mutations, which have a sensitivity of 80% and a specificity of 95%. So I'm using molecular analysis more frequently and serially to see if even if we don't necessarily see a morphological change by imaging, whether you're seeing a microscopic or cellular change in some of these cysts as a way to guide us and perhaps be a little bit more thoughtful about who's progressing and who's not. So I'm going to conclude here. Basically, I hope I've conveyed to you that there's this wide spectrum of solid and cystic lesions. CT and MRIs remain the workhorse for diagnosing these lesions, but they do have some caveats. EUS, FNA is safe. Core biopsy needles have come a long way. Molecular profiling, both of solid and cystic lesions, are increasingly being used. I think there's a lot of interest in early detection of adenocarcinoma in high-risk individuals, and that neuroendocrine tumors like cysts are, I think, increasingly becoming the incidentaloma from increased use of MRI and CT imaging. And with that, I will stop there and open it up for any kind of discussion. Thank you. Hold on, there's a. Okay. I don't see anything in the chat, so I guess I was super clear.
Dr. Park, I was wondering if you could elaborate a little bit further on that flow chart where you had 3 centimeters or larger pancreatic lesions. There's a statement in the guideline there that says you alternate between EUS and MRI. Can you elaborate more on that? Why do you alternate?
Yeah, so you're referring to the algorithm I showed on the consensus guidelines, right?
Correct.
Yeah, so so basically, as I said, what those guidelines did was they created this lexicon of high-risk stigmata versus worrisome features. And a cyst that was greater than 3 centimeters in the past was actually considered appropriate to recommend surgical resection, but that's no longer the case. And if you think about it, that kind of makes sense, because why does a 2.9 centimeter cyst versus a 3.1 centimeter cyst really make a difference? It's really a continuum of risk. And so greater than 3 centimeters became a worrisome feature. But in addition, as I alluded to, there's other features, including the presence of pancreatitis in the setting of an IPMN, the presence of a nodule, which may not be entirely enhancing, a mildly dilated duct between 5 and 9 millimeters, which suggests that you may have a mixed IPMN, or you may have some duct obstruction from the cyst, as well as distal atrophy often suggests that there's main pancreatic duct hypertension leading to atrophy and a delay in secretion. So those are the worrisome features, and the idea is that you would risk stratify them further by doing an endoscopic ultrasound. And if you didn't see a tumor or something that would suggest a need for surgery, you would put them in a surveillance regimen. And it basically starts, the idea was you would put these patients into yearly MRIs, because we're talking about serial active surveillance. So you don't really, and in a time when we're more conscientious of radiation exposure, MRIs are really the test of choice. Now, as the cyst gets bigger, if you're dealing with the 3 centimeter cyst, the question then becomes, how soon, how often should you do this? And at what point, if the pretest probability of high-grade dysplasia increases, then you may actually want to do endoscopic ultrasound to look for subtle, smaller tumors in the cyst. I should also say that an important point that the Japanese were very clear about in their studies were showing that, IPMNs are really a field defect. And so one of the reasons why you're actively following these cysts is not necessarily because the tumor is going to originate from the cyst in question, but it actually may be a field defect that there's about 5% of cases of adenocarcinomas that arise out of an pancreas with an IPMN that actually is a separate, that's actually found. For example, you might be following an IPMN, a cyst that's about 3.5 centimeters in the head of the pancreas, but the tumor is actually in the tail and is actually not growing from the actual cyst lining. And so that's also why you're not just looking at the cyst itself, but the whole pancreas, and you're really doing kind of a screening of sorts for the rest of the pancreas. And so that's why I think as the lesion starts to grow and look more of a worrisome cyst, then you may want to alternate between EUS and MRI. And I'm actually preferential to that because as I alluded to before, I think the pendulum is swinging in the sense that I'm actually doing a little bit more FNAs because I am aspirating the fluid, I am doing more molecular profiling, and I'm more interested in looking at the KRAS, GNAS profiling plus the allelic frequency. And I think, if you think about it, that's probably giving us more mutational information than an MRI or CT. Now, we've been fortunate that the MRIs and CTs are, have kept us out of trouble, but I think we can be doing better, particularly when we're trying to find these earlier lesions.
See,
Did that
thank
answer
you.
your question?
Yes, actually, you also answered some of the other ones that I was going to ask follow up. So I guess you use the EUS to also track the pancreatic duct, especially if there is some dilation seen on imaging.
Yes.
Let's see. Thank you.
Thank you, Dr. Park, for that informative lecture. We do, before, if anyone has any questions, we do have some polls that we'd like to conduct first. Danny, I think. Okay, great. So hopefully everyone can see some of these questions. Question number 1, what is the lifetime risk for pancreatic adenocarcinoma? And then I guess you guys can read it to your own pace. We'll give you probably a few minutes. Only about half of the people have voted, so if we'll just give a few more minutes. Okay, hopefully you guys could see this. So for question 1, lifetime risk for pancreatic adenocarcinoma, seems like it was between 0.5 and 1.5%.
B
Dan,
is correct. Yep, B is correct.
so 1.5%. Question 2, for the 75-year-old gentleman with multiple pancreatic cysts who that were found incidentally, he seems like has intraductal papillary mucinous neoplasm is the correct answer. I think it was a tie between that and pseudocyst, but the answer is C. And then for question number 3, neuroendocrine tumors on CT imaging will have hypovascular appearance during arterial phase of IV contrast. False. So it seems like a lot of people got that right. So this was part of the pre-test. And I think that's it. Do we have another poll, Danny, or is that?
That was it. Thank you.
Okay, great. All right. Are there any other questions that people have or comments? No. Okay. Well, thank you so much for your time, Dr. Park. It was a great lecture. We learned a lot about I know it'd be great to learn about some of your some of your work in the future as well. But thank you so much for coming today.
Thank you for having me. Have a nice evening, everybody.
Thank you.